Good morning, audience. Sorry for my voice. I got a little cold yesterday. So today I'm going to talk about another different topic about pain management because sympathetic block is also very important. I am now the director of my own clinic in Taipei, and previously I'm running a center about regeneration in my previous hospital. So today's topic, I use only 5% dextrose, that is a glucose water, for the vagal nerve hydrodissection. Because the sympathetic nerve, if we use too much anesthesia agents, we may deliver Horner syndromes. So I now use 5% dextrose now. Okay, this is the first case. So you can see this patient has replaced the intervertebral disc, and her neck is very stiff. But luckily, there's no instability, but she still complains a lot. This 65-year female has a lot of neck stiffness, poor sleep. She cannot sleep over 3 hours, and she also complains about upper limbs numbness and GERD. And she also mentioned about qi xie bu shun, that she cannot feel everything very goes smoothly. So I started to use like Neurotin or methylcobalt for conservative treatment, but the response is not so well. So I planned the X-ray survey and for the facet injection first. Then I will arrange the MRI for further survey. So after 2 times of the facet survey, her neck stiffness is getting better, but she still complains about a GERD, poor sleep, and cannot feel his body going very smoothly. So I remember that I heard a speech before by a rehabilitation doctor, and he said that if everything goes to your head, you cannot think very smoothly, you should go back to think about your neck. If you have sounds like popping or grating sensation over your neck, that means you may have some subclinical unstability. Because the sympathetic chain will pass the C1 and C2, then going down to the neck before the longus colli. And for the sympathetic chain, we have 3 ganglions. The most familiar one is that we always inject the stellate ganglion for like CRPS or for like you cannot define the upper limb pain. But the sympathetic ganglion also has middle and upper ganglion, and we cannot inject it very easily. So I go back to see his old MRI and the old CT. And however, at the C12 level, since everything is good, the foramen is open and the fat plane is still good. And also the MRI you can see. So this is the upper cervical ganglion we can see on the paper. It's a thick arrow. So this patient also has a good fat plane here and a superior cervical ganglion here. So maybe this is not the site she was compressed. And by the way, if you want to inject this very high sympathetic ganglion, maybe ultrasound is a good method, but it needs a lot of technique. So myself has not performed it yet. And if you can put the probe just beyond the SCM, and you can see the diversion of the ECA and ICA, then you just put a needle before the longus colli, it may have successfully injected the hydro. So when we see lower, it's the level where she got replaced of his IVD. Because of the metallic artifact, you cannot see the fat pen very well. And we see lower. So at this level, you can see the left side flat plane just behind the thyroid gland is good, but over the right side, the flat plane just disappear. So this is maybe the level of her compression. Then because if we want to test vagal nerve's function, the vulva test is a good test. The bedside will not elevate when you say R. And luckily, this patient just received an endoscope in September. So you can see her vocal cord. One side is not moving. So this may be compatible with the vagal nerve dysfunction. So stellate ganglion injection is not very difficult. Everyone can do it. You can do it just punch through the thyroid to put a needle in front of the longus colli. Okay, you can use ultrasound to do it by lateral approach. Just put your needle beneath the carotid sheath, and the 5% glucose water may fill the place in front of the longus colli. And one tip about the injection is that when you let the patient lie decubitously and ask him to rotate his head, the carotid artery will leave the cervical anterior tubercle more long, so the injection will be more safe. So this is my picture. This is the anterior tubercle of the cervical vertebra, and I use the ultrasound guidance and just put a needle beneath the carotid artery. So this patient is quite effective in the reports. After the 8 weeks, everything will go better, and it also happened in my patient. There's no GERD after her injection about 1 month because I do the injection in September, and her pain score after the injection of facet and the vagal nerve, the pain also reduced from 8 to 2. But she still have some sleep issue, but it's getting better now. So the symptomatic chain hydrodissection is quite effective. And we can also use CT guidance, but it may be too trouble for us to do that. But if you want to see how the contrast medium spray, you can also do it under ultrasound and fluoroscopy guidance. But however, when we image that the contrast medium may go upper to the middle or superior ganglion, it will not happen anytime. So if you fail to treat a patient after the stellate ganglion injection, maybe we should try the superior cervical ganglion, even though it's more difficult. Okay, so there's a paper say that after COVID, we have brain fog, or we have some weird symptoms you cannot explain. Maybe we should try the stellate ganglion injection because it's easy, safe, and it may help a lot of the sympathetic or parasympathetic syndromes. Okay, so we have another case. It's a young, relatively young male, and he has C45 HIVT, but he never got any operations. And he also complained about neck stiffness, poor sleep, and the personality of him is very special. He always feel very tired after COVID. And even though I give him many medication, many B complex, and I do the hydrodissection or injection, now he is getting better, but he still feel very tired. So I cannot explain it. But anyway, I just do the injection as my knowledge goes. So this is his X-ray, the lateral view. You can see as the C45 level, there's a big spur compressing the spinal cord. And I saw his outpatient MRI is also very severe. So under fluoroscopy, I do the facet injection and the epidural steroid injection. So his neck stiffness is getting better, but this time, instead of using a VOVA test, I just run the sympathetic and parasympathetic automatic nerve system check in my clinic. So as you can see, his sympathetic tone is very, very high. I think because he's a worker in a very high pressure company, maybe like Korea, everyone is in a high pressure. So this is why he's feel very fatigued. But however, I cannot persuade him to do the stellate ganglion injection because he's very feared of injection anymore. After the epidural steroid injection, he feel a lot of dizziness and he cannot tolerate Lyrica after the medication. So I gave him omega-3 oil and B vitamins. He's feeling better now, but still the sympathetic tone is very high. So now this is the last case I can share. This is a writer using a lot of computers. We can see that his neck is very stiff, but when we run the dynamic test, so you can see the neck is very stable without any movement. So I did not do any injection for him. This is a quite valuable image because when we see a stiff neck, we always think that he has something, maybe HIVD or unstable-ness. But when we run the dynamic test, we can see that his problem is not neck. So when I go to the internet, I saw a doctor in America also run this dynamic test. So you can see he just do the X-ray obliquely to see the foramen, and he see the foramen stenosis here in a dynamic test. So after 2 times of injection, you can see the foramen. Okay. You can see the stenosis of foramen is getting better now. So this is very valuable. We can explain to patient that how success is our injection. Okay, thank you so much.